All right, welcome back to Ultrasound Grand Rounds. Again, this week, I'm pretty excited to be back with you. As always, I have a very special conversation and a special topic to talk with you today. But I have a question for you as we get started. Have you ever thought that the ultrasound probe that you use to save lives could actually be the very thing that kills your patient? You know, we hold in our hand a very powerful tool, but it also has the potential to be a very potent vector for harm. And every time we scan, we have the chance to improve outcomes, or if we're not careful, to spread infection. And today we're going to get really practical and we're going to talk about how we can keep our probes and our patients safe. And to help us get this right, I'm joined today by Kristen Stannert from our infection prevention office. You know, she's one of our infection prevention specialists here at MetroHealth, and she has some really important and helpful information as we take bedside ultrasound to the next level. So thank you, Kristen, for joining us and help us navigate this really, really important topic.
Yeah, thanks for having me.
All right, so let's jump right on in. So Kristen, first off, thanks for being here. Tell us a little bit about yourself. Obviously our audience is a lot of clinicians and a lot of people who do bedside ultrasound or want to learn bedside ultrasound. And this may be a little bit of a different topic for us. So tell us about you, how long you've been here at Metro, kind of your role here, and what you do at MetroHealth to improve our ultrasound, improve the care of our patients here.
Yeah, so I came to Metro in 2014, so I've been here just over 11 years. I started out as a nurse in the ICU, and then I transitioned over to ambulatory care for a little while. And while I was doing ambulatory care, I got involved in the quality role. So there was a quality improvement facilitator, and then I was also the research facilitator. And in that role, I just really found a love for quality and just the research and quality improvement projects and things like that. So I'm seeking out a job in the quality department. And I stumbled upon infection prevention, and I honestly didn't really know what it was when I first started. And a lot of people don't really know what the infection prevention role is. So as I got into it in 2019, it was about mid-year. So I was about 6 months into my role when the pandemic hit, which was a really, really interesting time to be an infection preventionist, let alone being so very green in my role as well. So I've been doing infection prevention now for about 6 years.
There is nothing like COVID in a nation or a worldwide pandemic to really drive in this whole idea of how to avoid and prevent infections.
Yeah, it really gets your feet wet,
especially in the emergency department where it's like just not anywhere closely to controlled chaos.
It was crazy. Yeah, for sure.
Gotcha. So let's get started today. Let's talk about infection prevention. And so my idea here is that this conversation can be a guide, right, for people who are watching our channel. Can be somewhat for. I guess it depends on what level you're at, right? If you're a resident, you can understand a little context that your ultrasound director is developing right here with their ultrasound program. Or if you're an ultrasound fellow, because we know we have some fellows watching. If you're a fellow, this is something you need to know as you go out and you need to set up a program and be mindful of infection prevention. And then if you're a clinician, again, or someone else in the hospital, you may want to know some of these infection prevention pieces to know how to improve the quality of an ultrasound program. And so I think this is a really good topic for us to talk, even though it's a little bit off the beaten path for how to make a diagnosis with ultrasound. I think it's gonna be really, really helpful. So I'm pretty excited. But again, let's start with the big picture, right? So we have a whole bunch of clinicians who are listening to us. Why should, and we're just gonna talk to an ER doc because that's who we are. But if you're an ICU doc, put that in. If you're a surgeon, put that in, right? You're special too. But why should an emergency physician care so much about infection control, specifically with bedside ultrasound?
Yeah, so I think ultimately people like to go to, our regulatory bodies, right? So we're going to look at Joint Commission, things like that. However, I think that the ultimate purpose of the Joint Commission is just to do the right thing. Like they are just kind of checking in on what we should be doing. So I feel that, just the proper cleaning, starting when you walk in the room with hand hygiene through the whole probe reprocessing, following the manufacturer's IFUs, things like that, are not only because we have to, because someone's checking in on us, but because it's the safe and right thing to do.
And that's one of the things that's kind of surprised me a little bit as I've grown in various different phases of my career and different levels of working in an ultrasound program is, the Joint Commission is always that evil person that comes in a suit and just tries to screw up our patient care process. At least that's the way it was viewed, when I was younger in my career. And if you're in the Joint Commission, sorry. But that it's when we have a joint commission survey, there's a lot of stress that happens in the department trying to make sure that we are, crossing our T's and dotting our I's. And we're always trying to do that, just to be mindful. But I've come to realize that they're actually, it's a necessary part, right? It's a part of our accreditation. We have to be Joint Commission certified to receive our accreditation as a hospital to be able to care for and bill for Medicare and Medicaid patients. So there's definitely a regulatory component to that, but it's also like the intent of the Joint Commission. I learned this when I had an incident, a quality incident where I had to meet with the Joint Commission and review that quality incident. They weren't trying to get me. They were just like, hey, you know what? We like props to you being a doc and doing what you're doing. We're trying to make sure that what you're doing is done in the safest manner possible so that everyone can succeed, right? You as a hospital can do well. You as your patients can do well. And so I've come to see them as kind of an ally, as it were, but someone that does create a lot of stress for us when we're here. But yet they are very involved in kind of this infection prevention part as we try to figure out how to make our machines as safe as possible for our patients. And so as we kind of move on with this talk, we're going to kind of keep that in mind. But the other thing I wanted to really point out, maybe I'll say it here just so I don't forget it, and then we can come back to it later if it comes up, is what we say here. And Kristen and I were talking offline before we got started. What we say here, there's going to be some general principles that apply to everyone, right? And we'll try to highlight those, but there's also going to be some specific things that apply to MetroHealth, right? Things that we do in ways that we manage infection prevention that may be slightly different from your institution. So as always, follow your institution's specific protocols and guidelines if there's anything that differs from what we talk about. But you can perhaps use what we do here as a model for kind of maybe how you can proceed forward if that fits your bill at your institution. So you think that's fair?
Absolutely.
Gotcha. So let's segue a little bit. I think as we try to understand, we understand the why. We don't want to kill patients, right? There's nasty bugs, right? And you guys know this just as well as I do. There's bugs that have super weird names that are very, very hard to kill, and our infectious disease colleagues, pull their hair out on a daily basis over which antibiotics to give some of these. And if we can prevent that, an ounce of prevention is worth a pound of cure. If we can prevent that on the front end with some quality measures, starting with hand hygiene, and then moving on to probe and machine maintenance and issues like that, that's going to go a long way to improving outcomes. So as we transition from the why, let's get kind of into some specifics of the what. And as we've worked through this, and as you and I have talked, there's different levels of disinfection. Clearly we don't run ourselves through a sterilizer every day, right? But yet we also don't just wash surgical instruments, with soap and water. And so, Kristen, help us understand a little bit of, the levels. Actually, before we even get to levels, kind of the classification of instrumentation or things that we observe in the hospital. I mean, a person's very different from a scalpel, which is very different from an ultrasound machine. So how do we wrap our minds conceptually around these things that we use, right? Because they're all fomites, all potential sources of infection. Mm-hmm. And then as we maybe understand the classifications of things, then we can maybe understand the classifications of the what we do to clean the things. So
yeah, so here at Metro, we start with the Spalding classification system. So this is how patient items are classified into different categories, whether they need a high-level disinfection, a sterilization, or a lower intermediate disinfection. So these are broken down into critical, semi-critical, and non-critical items. So your non-critical items are going to be things that just touch, intact skin. So we're talking like stethoscopes, blood pressure cuffs, things like that. And then you move into your semi-critical items. These are going to be your anorectal probes, your vaginal probes, surface probes that come into contact with non-intact skin. Those are going to be in that semi-critical classification. And then anything in the critical classification is going to come into contact with, the vascular system, any sterile tissue, sterile spaces, things like that. So that's, anything that scalpels, mostly things, that you'd find in the OR.
Gotcha. So the way I like to consider it for our context is we're mostly critical, semi-critical. I'm sorry, I said that wrong. We're mostly non-critical and semi-critical devices with bedside ultrasound. Most of our scans are done, external body on intact skin. We have a nice, epithelial layer that we're dealing with. It's got its own immune barrier, like all the immunology stuff that we've learned long, long ago. And so all that's going to be the non-critical. Like I just go up and do a gallbladder ultrasound, I touch the patient, but there's not a lot of, risk of transmission to a patient who has an intact immune system. However, we want to make sure our device is clean, right?
Right.
Whereas the semi-critical is when we kind of get into the realm of doing the intracavitary ultrasound. So if we do, I know, in previous lectures on this channel, Dr. Werner's talked about how we do transvaginal ultrasound, right, for OB. We've had, various speakers talking about transesophageal echo, right? We did one last year with Dr. Phillips in the ICU and Dr. Owens here at MetroHealth. And we've had different lectures there about how we can do endoscopic ultrasound, during these codes with TE. And so all these things that interact with mucous membranes would be that semi-critical, right? It's going to need a little bit more disinfection just because of the pathogens that are there and the fact that there's a little less host defense that's innate in these mucous membranes. And then when it comes to the critical, this is going to be something maybe for Dr. El Hayek that we talked about last year when he did, the intra-operative ultrasound. But in the emergency department, we're really less down into the critical environment in terms of, the level of classification, for us in the department. So.
Yeah.
So how does this impact the level of disinfection? Like what levels of disinfection, or maybe we should talk about the levels of disinfection. And then we can kind of pair them up, do that little game where we match them up. Which level of disinfection fits within the context of which classification of device?
Yeah. So when you look at, a low level disinfection or an intermediate level disinfection, that's going to be all your hospital approved disinfectant wipes and sprays. Here at Metro, we have, a set set of wipes that we use within the system. And then our EVS system or our EVS employees use a particular chemical themselves. I'm going to pause here. So can I brand names and things like that? Like where are we at with stuff like that?
We can use brand names, understanding that, this is specific brands that we've chosen, but there's a variety of brands. And so we don't represent or we don't endorse one particular brand over other. It's just what we've chosen at our institution. So
I just didn't want to speak to different brands. So, Oxycide is something that, that our environmental services department utilizes. There's special training that goes into that chemical use. So they exclusively use it. Whereas then, nursing, bedside staff, clinicians, things like that, they'll use the hospital approved disinfectant wipes.
One of the things that we've struggled through, I think is the appropriate term, and struggled in a good way. It's not like a adversarial, but like wrestled with, is how to pick a disinfectant for a particular device. And maybe we're getting a little bit off topic for the kind of line of thinking that we're going through right now. But I know one of the things that's been important for us as we think through particularly these low level disinfectants is what disinfectant is approved for the device that we're using. And fortunately, there's a lot of overlap between devices, but there's, unfortunately, a lot of, manufacturer specific, you can use this, but not this, and this, but not this. And it comes down to warranties and which probes are tested with which chemicals and things to that effect. And so this is where Kristen pulls out her hair, trying to marry up all these and say, instead of buying these 32 different types of, sprays, here's the one or two that we might need to maximize our effectiveness in this classification level.
Yeah. So we really struggle with keeping the amount of different disinfectants down. We try to make sure that what we have in-house is appropriate for what the manufacturer's instructions for use are calling for. So you can imagine, the amount of times that we've looked at things together for equipment, put that with every other department throughout the hospital. There's a lot of different needs. So we try to, recently we've kind of gotten involved in looking at the equipment coming into the hospital and reviewing those IFUs before the equipment even gets approved to be brought into the system to ensure that we have the proper disinfecting agents to be able to clean these, which I hope moving forward will help us not to have such a wide variety of pieces of equipment that require so many different disinfectants.
And this is one thing that we've worked on as an institution. We're continuing to work on it, is streamlining just the acquisitions process of equipment, right? And this is a whole different topic, whole different conversation.
Sorry, I opened that can
when
of
it comes down
worms.
to like how to just, when you're setting up a program, how to buy a device. Because we just go out there as the clinicians, like, that one's pretty shiny. I like it. It's got all these bells and whistles and buttons that I like. But there's a lot of other factors that come into play when it comes to buying a piece of equipment. One of which is that infection control. And so one of the things that's really helpful for us, and one thing that's helpful for you guys, is to really reach out to your infection prevention team early so that we can just be on the same page as it comes to, how are we going to clean this thing, right? Because it'd be a shame to spend a ton of money on buying a machine and then infection prevention is like, sorry, I can't help you, or like, you can't use that one, and oftentimes it comes down to like making sure we have the right disinfectant. So it's not like it's a huge game changer, but just streamlining operations by creating these efficiencies, in terms of our purchasing. So
I actually just recently had to create a whole new policy and procedure. We had to bring in a new chemical for high level disinfection because there was a piece of equipment that got brought in, and they didn't review the IFUs or what it actually needed before they brought the equipment in. So now we owned this great piece of equipment and we didn't have a proper way to high level disinfect it.
Whoops.
So we had to bring a new product in and create a whole new policy and procedure for this one department.
So that was a fun tangent. Let's kind of circle back a little bit on this idea of low level disinfection, right? So maybe if we back up and think a little bit more scientifically or clinically, what are we trying to kill with low level disinfection? Like, what particular pathogens are we thinking of? What are we missing? Maybe is another good example, because there's probably a smaller list with low level disinfection.
Yeah. So we rely on the EPA lists to validate the disinfection kill claims that each product has. So your general disinfecting wipe is going to be good for the majority of what you're trying to clean. And then we have specific wipes, let's say the bleach wipes, for example, when you have a C. diff patient. Or we have the purple top wipes that we use in-house here for when we have a Candida auris patient. So we use our blanket disinfectant wipes for the majority of everything. And then you have to have the sporicidal, like we said, for the bleach when you have the C. diff patients. And then the purple top wipes, like I said, for the Candida auris. Gotcha.
So basic level disinfection is going to be a bajillion viruses, including COVID, influenza, HIV.
Those are easy ones to kill.
C. Yeah, all those things. And then a whole bunch of different bacteria, including our common skin flora, and it's like Acinetobacter in there, and Enterococci, and all those.
So it's the sporicidals that we really struggle with. So we have to make sure that we have a specific cleaner for those spores. Again, like C. diff. And the chemical that EVS uses is a blanket chemical, so they don't have to worry about switching chemicals in between. They don't have to worry about what the patient had or what they were carrying around with them. What they use kills everything. Gotcha.
And so the sporicidal and the fungicidal would land us still in that low-level disinfection.
Correct. Yeah.
Now, one of the things that has come up for us that's been a unique challenge, and I'm going to admit, we don't have a lovely, beautifully packaged in a bow solution for this one. We've got this will work, and we've agreed with the different manufacturers about this, is C. diff. It's just just a nasty bug.
Yeah, it doesn't like to go away. That's the problem. It doesn't. It likes to live on surfaces for a very long time. So we have to take extra measures.
Yeah, and unfortunately, the only thing that kills it is bleach, and lots of it, right? And also, unfortunately, when you look at the manufacturer's IFUs, they say, hey, great, you can use a lot of different stuff except for don't use bleach because we will not support you. And
it's going to ruin your equipment if you use it.
It's going to kill your equipment. Sparks will fly. Things are I'm kidding, but like it's not good for your equipment. And so we've had to struggle through that one, right? Like either you harm the patient or you harm the probe. What do you harm, right? And the solution that we've come up with for now, and again, this is just, we've agreed on this with our different manufacturers, is to power off our equipment, bleach it, wipe it with a wet rag to get all the bleach off after it's sat there, and then dry it all off, and then power the equipment back on, and then pray that nothing happens.
Yeah.
And that's the best we can do as of right now.
Yeah, it's not the ideal situation, but otherwise, you guys bringing your stuff from room to room is, you don't want those C. diff spores living on there.
Exactly.
Yeah.
So let's move up to intermediate level disinfection. So what is intermediate level disinfection? We'll kind of ask the same question. What is it? How do we do it? And what does intermediate level disinfection kill that low level doesn't?
So intermediate is just going to kill a broader spectrum. It's on the same, level. So like it's still in that non-critical category. So your low level and your intermediate level are still just going to be your hospital approved wipes and things like that.
Gotcha. So I guess we want to bump up to then the high level disinfection.
Yeah.
Tell me the difference between that and low and intermediate level and what it kills.
Yeah, so high-level disinfection is going to kill everything, except it's going to leave some spores behind. So that's the difference between sterilization, where sterilization is just going to kill everything, and that high-level disinfection is just leaving a small amount of the spores behind. So.
Gotcha. And so for those of you guys who are out there, common forms of high-level disinfection, again, getting into brand names, we do not support or endorse or receive any money from any of these brands. So this is just pragmatic, right? The Sidex OPA is a very labor-intensive chemical bath solution for high-level disinfection. And then the Trophon, does that have OPA in it too?
No, that's a hydrogen peroxide.
Okay. Trophon, it has a bunch of letters at the end.
Yeah, so currently there's different machines. So the EPR is like the older one.
There it is.
Trophon 2 is the newer one, but it's a vaporized hydrogen peroxide.
Gotcha. And so those are both going to function at that same high-level disinfection level to provide that form of disinfection for the probes. I guess we're going to let give a little bit of a giveaway here. It's going to be for that semi-critical level. Right? We're going to do that little matchup game, and I just gave you one of the answers. So basically, high-level disinfection then covers all the low-level stuff, plus some other agents that are going to be critical for these mucosal membrane exposures, right?
Correct.
So we were looking some stuff up earlier, and it's basically the OPA or the hydrogen peroxide or these other different chemicals are going to be some sporicidal stuff, plus this antiviral, antibacterial. It's going to give us a cleaner environment for these mucosal membrane exposures. Is
correct.
What I'm basically my understanding. Is that correct?
That is correct.
Perfect. So, and then we get on to the sterilization, the critical, and that's going to be all of the above plus like knock out all the spores, right?
Correct.
And so anything that's going to be inside a body cavity is going to get this sterilization. So I guess if we do that, like I said, that game that we keep coming back to, low and intermediate level disinfection, right? The sprays is going to be for your non-critical exposures, right? The high-level disinfection, so your OPAs, your hydrogen peroxide, et cetera, is going to be for your semi-critical. And then, or did I say that right?
Yes.
Yeah, semi-critical. And then your critical, the surgery, the OR, these intraoperative
anything in the
suites.
bloodstream, yes,
that's going to be sterilization.
Mm-hmm.
Perfect. So you mentioned something, and I want to come back to this one because I didn't realize this one or didn't know this existed until a couple of years ago. EPA List K.
Yes.
Right. So I think the most among the lettered agencies, I'm going to make a lot of friends here. Among the lettered agencies after the Joint Commission, probably the most hated and most feared are like OSHA and EPA, right? Just because, again, we interact with them routinely. And so help me understand, what is this EPA List K? Like, what is the government doing here with this list?
Yeah, so they have a slew of lists.
It's the government. That's what they do. They create lists.
Yeah, so the K list specifically is for C. diff, right? And so they have them. We had one for COVID. We had one for MPOCS. And so they come out with these lists. And so what they do is they take a look at all the disinfectants and they make sure that what the companies are claiming that they're going to be killing, that they're actually going to kill those microorganisms.
So how do we use, great. So, I pay taxes. I file my 1040, and that 1040 goes to pay someone in a suit who's making a list. Great. What do I do with this list?
Yeah. So
sorry for that. Highly cynical, right? But
So-
what do we do with this list?
the lists help guide us on the selection of disinfectants that we're going to bring into the hospital, because we want to ensure that if we're taking the time to use these, that it's actually doing what we want it to do. So like I said before, we have just a few select disinfectants that we brought into the hospital to kind of minimize the footprint. And we reference those lists to make sure that what we're using matches what we're trying to kill.
Gotcha. And so I guess where it comes, from my perspective, where it comes down to it is I want to, develop a program and buy equipment and, figure out what the disinfection is and all that stuff. We have resources, right? EPA List K, your infection prevention, your manufacturer's IFUs, and you can basically take all these different resources and find, okay, this agent in the IFU is on List K. And so I know when I go to my infection prevention that they're going to say, wow, you did your homework. Thank you for making my job easy. And then when the Joint Commission comes in, they say, wow, you've done your homework. Your program is great. I'm going to move on and pick on somebody else now. Is that about right?
That's about right. Yeah. If we can give them the answers, they will move on pretty quickly. But yeah, I think it's the onus of the department to know your IFUs, right? So your
Absolutely.
equipment, you need to know, how to use it, how to run it. It's also your responsibility to know how to clean it properly. So we look through those lists that the manufacturers give us, and we match it up to something that we already have in-house.
Yeah, so it's basically just a cheat sheet for how you can guarantee that you pass your Joint Commission inspection. In fact, that should be the title for this lecture. It should be how to pass the Joint Commission inspection guaranteed.
Guaranteed.
And then like some clickbaity, thumbnail like that. That'll be it right there. But yeah, it's a cheat sheet for how you can set things up and kind of know that this is going to go through without a lot of headaches and fuss and arguments.
Yeah.
And on the flip side, like for us, we have a sonographer that helps us, with the day-to-day logistics of our program, right? And she is the most organized person probably in Northeast Ohio here, but has notebooks full of, the manufacturer's IFUs for all of our machines, right? She has handwritten spreadsheets of here's the machine, here's all the different agents, here's which ones, are approved for the machine, here's which ones are approved for the probes. And so when Kristen and her team comes down for the annual inspections, it's pretty easy. Diane pulls out her book and it's like, boom. And Kristen say, hey, this is great. And
she's
Bob's your
amazing.
uncle.
I often ask her if she can come with me and organize everyone else's binders to be the same. But.
Now, what you don't know, and she'll probably hate me for this, is that she is stressed every time we have an infection prevention, and they always go great, right?
They do. She has no reason to stress. She
But
does an amazing job.
whenever the infection prevention, audits are coming up, it's just, we make sure everything's, nicely in a row and it goes great.
Yeah, I tell people, it's an open book test, right? So they do audits on themselves every month, and I come in and I do the exact same audit. And then your policy and procedure and the manufacturer IFUs. It's all written out for you already. And as long as you're following those, then you got no worries.
All right, so let's get really practical here. This is all great information, right? We've talked a little bit about, the Spalding classification for devices. We've talked about the different agents, right, that can match up with those different Spalding classifications, even the List K, that open book test, like that cheat sheet, as it were. But if you're just the line physician, right, and I don't mean just the line physician, like if you are the line physician, right, and you are using this equipment and, you probably don't care about, which agent are we going to pick, and you just have one, right, you're going to use it. And so talk to us a little bit to that person about just the practical day-to-day, I'm using the machine. Now what do I do, right? I just wiped off the probe. I got all the gel off the probe because, the worst thing you can do to yourself or your colleagues is leave gel, particularly bloody gel, on a probe. Like, don't. But I've just wiped it off. What do I do? Like, I need to put the machine back. I'm going to get back to my work. But what should I do before I do that to do this infection prevention stuff?
Yeah. So like you said earlier too, like you guys work so hard to treat these patients, and the last thing we want to do is add more problems by adding more infections. Hospital-acquired infections are, it's my job. It's what I do. I try to avoid them. So you guys being frontline, being with the patients, are directly involved in making that happen. So knowing what you're using and how to use it is super important. If you know that you are using a low-level disinfectant, you know that you're going to go in with the wipe and you're going to clean it. Our products are really great because on the canisters themselves, they have the dwell time written on them. So like you said too, cheat sheets are always allowed. So look at your canister, know what you're using, and then also knowing knowing when, but then if you need high level disinfection, knowing where you're going to achieve that at.
Yeah. And for the program directors, like you should probably have the high level disinfection plan set up, the policy set up so that the line physicians can say, well, this is when I do this, here's where I take it, right? We have a system in our office and then we use there. But you use the term dwell time, right? And I know what you mean, but I just want to make sure we're all clear on that. What is dwell time and what does that mean for the physician as they're cleaning their probe?
Yeah, great question. So it's dwell time, wet time, contact time. It's known as several different things, but what that means is that is the amount of time that the manufacturer has deemed needed for the equipment to be disinfected, to kill everything that they're claiming it's going to kill. It has to stay wet for that amount of time. So hopefully it just requires one quick wipe and it'll stay wet for that long. Sometimes, you have to go back and wipe it twice or use 2 wipes to ensure that it's saturated enough to achieve that.
And this is something I didn't realize until, well into my practice, because I always just like, I clean the gel off, spray it off, wipe it all down, put it back. It's all pretty and it looks great. But realize like when I did that, I basically made my disinfection half as effective as it should have been. Right. And so what we should do is, grossly decontaminate the probe, right? Get all the blood off, get all the gel off, make that clean, and then spray the probe cord and the holder and leave it. Right, just let it sit because that dwell time. The each disinfection has its own dwell time. It's usually it's 3 to 5 minutes or so for most of them. Right, there's gonna be some outliers, and you want to let that chemical sit on those surfaces so that it can actually do the job that it's designed to do, and that's kill the bugs that we're trying to get rid of. And so that was, to me, a revelation when I figured that one out. I was like, oh, you're not supposed to just wipe it off and make it look pretty and clean. No, you spray it, leave it saturated, or you wipe it, leave it saturated, and let it kill.
Well, and I think a good point to add there too, you have to clean it before you can disinfect it, right? So if it's covered in gel, it's covered in anything, you're going to have to go in and you're going to have to wipe it, whether it be using one of the Sani wipes or using, a lint-free cloth or gauze or something to go in and wipe all that off first and then go back in with the disinfectant, because you can't disinfect something if it's not wiped off first. So it'll take 2 wipes. The first wipe is going to be to clean it, and then the second one to disinfect it.
And as we kind of get towards the end, I'm going to just throw you a curveball. You ready for this one?
I don't know. Let's see.
All right, let's do it. This is going to be fun. This wasn't on the list, but it came to my mind as something that's really, really important. And I know we've talked about it in the past. And I also know there's a little bit of disagreement in the literature about this one. And so it's kind of one of those gray zones. Right? You're really nervous right now. When do we cover our probes? Right. So there's a lot of different probe covering devices. We have, a couple that we've used here. We do use here. We have the probe sleeves. We have, these sticky things that are designed for probes, right? They're not Tegaderms, right? And I know I use a brand name, but Tegaderms are not approved by anybody for any purpose on a probe, right? So, but there are sticky devices that cover probes. And there's also the Diane favorite is a exam glove. For certain applications. But when do we need to cover a probe versus when can we just leave the probe uncovered? Let's maybe just keep it basic, the basic question there, because I think there's a lot of agreement in all the guidelines about that. And then the specific probe cover comes down to maybe specific applications.
Yeah. I just want to preface this whole topic
Go for it.
with saying that the probe cover does not negate the need for the disinfection.
100%. 100%.
Yeah, I mean, whether it be a low level disinfection or high level disinfection, it is still 100% crucial to follow even if you're covering it, to follow it with the proper disinfection.
Definitely agreement there. But now let's get into the controversy. There's a little bit of a controversy around when precisely you use a probe cover, right, on your probe. And, if you look at the Joint Commission, guidelines versus the, society-specific guidelines, and I'm thinking specifically about, the American College or the American Institute of Ultrasound and Medicine, but other guidelines would suggest, there's some nuance here. And so where we've landed on this one, and I don't think anyone has a great answer, but where we've landed on this is, for intact skin, right? Just your run-of-the-mill scan, you don't need a probe cover, right? There's enough barrier defenses between patient and patient, and then the low-level disinfection that we're going to do that's adequate. When it comes time to breaking intact skin, right? Whether it be through venipuncture or you have like a draining abscess, then at that point the probe should probably be covered, right? To just add an extra level of protection for the probe, as you transition the probe from patient to patient. And so what we do for all of our ultrasound guided IVs, all of our central line placements, anything that we're going to use the probe to assist in poking the patient, is that probe needs covered, right? It needs covered in a certain fashion. Now, the degree to which that's covered may change from procedure to procedure. So if we do a very, very low level, just a peripheral IV, right, that's a very different procedure than a central line, right? And so for central line, full sterile getup, a long sleeve, this is going to be a very sterile procedure. Whereas the peripheral IV, those are always placed, non-sterilely in the department if you don't use ultrasound. And so we're going to do those in a clean capacity with, and we order the sterile probe covers just to keep our ordering simple, understanding that, it's not the full sleeve that we're going to use for the IVs.
Yeah, so I think your prep field can kind of play into that too. So if you're on a sterile field versus just an aseptic prep field.
So there's a lot of controversy in this particular area. There's a lot of, departmental and hospital institution level, variables that come into play. And so this is definitely a place to lean into your own hospital infection prevention. But as we've kind of wrestled through this ourselves, trying to balance that tension between what is ideal and what is practical, or what is ideal and what is easy to get to what is practical. I think that's kind of where we've settled in for now, in that whole level of controversy. Does that sound fair?
Yeah, I think, the easier we make it for the clinicians, the more likely that it's going to happen.
Yep.
So we do lean into that for sure.
That's one of the things I've come down to is if you overcomplicate a process, the process fails.
Yes.
Right. And so for the best outcomes, simplify the process, including, hey, put the probe covers right next to your IV catheters so that you grab both and you don't have to go hunting for one or the other.
Yeah.
So.
Yeah.
Great. Now, this has been a great talk, and I think we're getting to the end of our time here. I really appreciate you coming and sharing your expertise. I think this is helpful.
Yeah.
Right? I think this is an important topic to talk about in this context. Maybe as we leave here, what are the top maybe three things, three takeaways that people who are watching this should remember for this particular topic, for infection prevention, specifically vis-a-vis bedside ultrasound in the emergency department?
Yeah, so I would probably be shamed by my colleagues if I didn't mention hand hygiene while I was here. It's the easiest thing that you can do to prevent infections. They say that there's about 50% of hospital-acquired infections that can be prevented by simply performing proper hand hygiene. So just make sure you're using it when you're supposed to and you're using it how you're supposed to. So that'd probably be my number one thing.
Dr. Counters would be very, very proud of you. His bow tie just got an extra polka dot.
And let's see, number two, I'd say probably use your IFUs. Know your IFUs. Be familiar with your IFUs. That is going to be your source of truth. That's your Bible on how to clean, run, do everything with your equipment. And then number three would probably be just know your hospital policies and your departmental procedures. Again, those are what we're held to. Standards can say all they want, but when they come in and they look at what we're doing and how we're doing it, it is ultimately how we have laid it out and how we said we are going to do it, that we need to be following that.
No, those are great. Thank you so much for that. And I hope you found this helpful. Like that, I think this was an incredibly valuable conversation to have in the context of just providing excellent care for our patients using bedside ultrasound. Like we talk about this all the time about how ultrasound can enhance our procedures or make these diagnoses, but this is really just the foundation that really supports all of that and makes all that possible. So huge thanks to Kristen Stannert for being here and sharing your expertise as we try to promote the use of bedside ultrasound for all of our patients. So thank you so much.
Yeah, thank you.
All right. I hope you found that helpful. If you did, hit that subscribe button down below, hit that notification bell so you'll never miss an episode of our Ultrasound Grand Rounds. And also let us know in the comments if there's anything that you found particularly useful or anything that you find at your hospital that we didn't cover that was useful as well. For more resources about our program, check out metrohealth.org/POCUS. And if you want more information about bedside ultrasound, how to run a program, check out the video on the end screen. Thanks, guys. We'll see you guys in the next lecture. See ya. Bye.